Components of a general anesthesia: hypnosis, amnesia, analgesia, regional anesthesia, areflexia, plus muscle relaxation. Sequence of events in anesthesia: identification of patient, assessment, anaesthetic plan, preparation, conduct of anesthesia, post-operative care. Assessment: history, general, anaesthetic history, examination, general, especially CVS, respiratory, airway, other relevant body part, Egel's spine, investigations. Assessment: a large part could be performed by caring physicians to minimize delays or deferments. Anaesthetic history: any previous anaesthetic experiences, any complications, difficult airway management, awareness, inadvertent recall of intraoperative events, allergies, post-operative nausea, vomiting, PONV, delayed emergence from anesthesia, genetic problems, rare, pseudocholinesterase deficiency, malignant hypothermia, nerve damage. Anesthesiologists then determine fitness for surgery, estimate whether there is sufficient reserve to meet increased metabolic demands from the stress of surgery and for healing, as there may also be some compromise in cardiorespiratory function from anesthesia, estimate risk of exacerbating certain comorbidities, ischemia, heart disease, respiratory failure. Anesthesiologists then determine the need for specialist consultations to optimize coexisting conditions, anaesthetic care plan. How do comorbidities in a patient affect the administration of anesthesia? Anesthesia and coexisting diseases, diseased organs, adverse effects of anesthetic drugs, systemic illness, pharmacokinetics, pharmacodynamics, drug interactions, effects anesthetic techniques. Anesthetic agents may adversely affect the respiratory system at every level: central control, response to CO2 and hypoxia, airway, reduce protective reflexes, work of breathing, resistance from breathing circuit, retained secretions, bronchospasm etc., lung mechanics, lung volumes, work of breathing, residual paralysis, gas exchange, VQ mismatch. Pre-existing pulmonary diseases, increases respiratory complications, intraoperative, coughing on induction, laryngospasm, bronchospasm, desaturation, post-operative, mucus retention pneumonia, respiratory failure. Anesthetic drugs affect cardiac performance, vasodilation, venodilation, chronotropy, ionotropy. Reduced cardiac output and tissue perfusion. Surgical stress alters hemodynamics. Increases metabolic demands, pain of surgery, reduced tissue perfusion, reduced cardiac output, plus reduced circulating volume from bleeding. E-grave may exacerbate myocardial ischemia. Perioperative cardiac failure. Inability of the heart to meet increased demand during surgery, increased metabolic demand, may develop arrhythmias, fixed cardiac output state, aortic stenosis. Reduced synthetic function, protein binding of drugs, impaired clotting, reduced metabolic function, drug metabolism and clearance, clearance of toxins, A-grave encephalopathy, circulatory disturbances, portal hypertension, ascites, high circulating volume, A-grave affect drug distribution. Reduced drug excretion, electrolyte abnormalities, hypertension, severe anemia, platelet dysfunction. Diabetes mellitus, associated CVS and renal problems, fasting and surgical stress upsets sugar control, diabetogenic hormones perioperatively, both hyper and hypoglycemia, detrimental to CNS. So, what do you do with the comorbidities? Optimize patient as far as possible for elective patients. For emergency surgery, do the best you can with increased monitoring and post-operative care. Respiratory function, lung function should be optimized. Before general anesthesia for elective surgery, stop smoking, treat infection, bronchodilators, steroids. Post-op care to reduce complications, supplemental oxygen, adequate pain relief, post-op physiotherapy, patient education, consider post-op ventilator supper. Cardiovascular disease, delineate cardiac risk, judicious investigations, optimize cardiac status, lifestyle changes, medications, valvular surgery, revascularization, appropriate post-op monitoring, effective post-operative pain relief. Other diseases, liver, treat coagulopathy, other supportive treatment, adjust drug doses, renal, consider prehydration, minimize nephrotoxins, diabetes, clear fasting instructions and treatment plan, omit oral hypoglycemic on morning of surgery, may require an insulin dextrose infusion, meticulous perioperative sugar control, frequent monitoring. Anaesthetic plan, type of anaesthetic, preparation, patient, staff, equipment and drugs and fluids, intraoperative management, monitoring, positioning, fluid management, post-operative management, analgesia, disposition. Preparation of the patient. Instructions to patient regarding their comorbidities in the perioperative period, medications, fasting instructions, other preparations, for example, bringing their CPAP machine to hospital. Conduct of general anesthesia, establish monitoring, A induction agent, A grave plus opioid, A grave plus muscle relaxant, A instrument airway, A maintenance agent, A positioning and protecting patient, A monitoring, fluid and drug management, emergence plus reversal agents, A recovery, post-anesthesia care unit ACU. Induction of anesthesia, the act or process of inducing or bringing about anesthesia, putting to sleep. Use of pharmacological induction agents, most commonly via the intravenous route. Inhalational route can be used. Common induction agents, intravenous induction agents, propofol, thiopentone, etomidate, ketamine, gas induction volatile agents, sevoflurane, nitrous oxide. Neuromuscular blocking agents, muscle relaxants. Non-depolarizing, short-acting, mivacurium, intermediate-acting, atracurium, cisatracurium, rocuronium, vecuronium, long-acting, pancuronium, depolarizing, succinylthonium. Maintenance of anesthesia, continuous administration of a maintenance anesthetic agent, usually in combination with an analgesic agent, inhalational or intravenous route. Maintenance agents, intravenous anesthetic, propofol, volatile anesthetic, isoflurane, sevoflurane, desflurane, plus nitrous oxide. Analgesia, simple, paracetamol, NSAIDs, intravenous, suppositories, opioids, fentanyl, morphine, oxycodone, pethidine, others, tramadol, regional technique. Reversal agents, to reverse neuromuscular blockade, not hypnosis. Nerve stimulator used to assess degree of neuromuscular blockade, neostigmine plus an anticholinergic, atropine, glycopyrrolate, sagamadex, for reversing rocuronium only. Post-operative management, analgesia, oral analgesia, parenteral analgesia, infusion, patient-controlled analgesia, continuation of regional block, epidural, catheters along major plexus and post-operative management, disposition, where do the patient go from here? Home, ward, high dependency unit, intensive care unit. If you are not sure, ask the anesthetist.